Hello, hello, everybody, and welcome to yet another, I think it's number 7, lucky number 7 episode of Facebook Live, Burning Migraine Questions. As always, my name is Ziv M. I'm a plastic and peripheral nerve surgeon specializing in the treatment of chronic headaches and migraines by a surgical approach. And I am here to answer hopefully many more of your questions with regard to various headache surgical procedures. So diving right in and continuing with many of the questions we have left over from many previous episodes. One patient asked, can thyroid surgery cause occipital neuralgia? The simple answer to that is not to my knowledge, but as always, there's always a but. And the but is this. One of the things that is a risk factor for neuropathy, neuropathy really means some pathology in a nerve. That's pretty simple in that regard. One of the thoughts in terms of a risk factor for neuropathy is hypothyroidism. So if you have a large portion of your thyroid removed, whether you have an overactive nodule, whether you have thyroid cancer, or for whatever other reason, and your thyroid levels are not managed appropriately following surgery, and you essentially become hypothyroid, which means your various thyroid hormone levels are deficient, it is possible that you could develop a pathology in your nerve that could cause occipital neuralgia. So it is not typically thought to be a risk factor for occipital neuralgia, but thyroid surgery, specifically hypothyroidism, is a known risk factor for neuropathy, and therefore the two may be involved. Another patient asked a very important question, and I think this is one that needs to be embellished a little bit. And this is, why are migraines on the left side or the right side, and why not on both sides? And the simple answer to that is migraines certainly can be on both sides. They typically occur one side or another, but sometimes they do occur bilaterally. Now, many of the patients that I see have been diagnosed as having migraines. Now, if you look at and don't take my word for it, go Google it and look at very reputable websites such as WebMD, etc. What is the definition of a migraine? Well, you'll find it's a headache with a certain level of severity. It's a headache that occurs this often. It's a headache that has X, Y, and Z characteristics. But at the end of the day, okay, you can describe it and you can say what it looks and smells like. But if you say, well, what causes it? That remains a mystery, and there are many known potential causes, but it's hardly the fact that we have honed on this is what causes migraines and therefore this is what treats it. Otherwise, we would very likely by now have a drug or an operation that has near 100% efficacy, and of course that does not exist, even as effective as the headache surgery we talk about a lot here is. So the question is, the point is that many of the patients that I see that are diagnosed as having migraines actually have occipital neuralgia. And the reason I like that diagnosis better than migraines is that if you can figure out which nerve is causing the algia or the pain, if you are diagnosed with that, in my hands, it means you very likely have a mechanical compression on one or more of those nerves. And therefore, we do have a surgical procedure that is likely to be able to provide you with relief and hopefully fairly permanent relief, okay? Now, when it comes to the patients that I see that have had occipital neuralgia or chronic headaches, you can call them migraines, you can call them cervicogenic headaches, whatever, for many, many years, a lot of them will tell you, if you really drill down on it, that they started off having right-sided headaches only, for example. And they had that for many, many years. And then after 5, 6, 7 years, all of a sudden they began to have left-sided headaches, and then the headaches were full-blown on the left side and were just as bad on the left side as they were on the right side. And the question is, why does that happen? There's no definitive explanation for that has ever been proven, but I think it is true to say that if you have nerve compression that is unchecked, you have progressive degeneration and pathology within those nerves. Actually, Lee Dellin proved that in a non-human primate model many, many years ago with his first fellow, Dr. Susan McKinnon. And therefore, if you have, let's say, right-sided greater occipital neuralgia, and you have persistent irritation or inflammation and compression of the greater occipital nerve on the right side, and that goes unchecked for many, many years, the inflammation is going to be throughout that entire nerve. And remember, when you look at a nerve either in a book or in a human being in an operation, the actual nerve, that wire that you're seeing, is just part of that actual nerve cell. It's almost like the arm in your body. The actual nucleus to that nerve, or the brain, if you will, is either just within the spinal cord itself or in a ganglion or a sort of a network of nerves just outside the spinal cord. So if there's inflammation along part of that nerve, eventually with time that entire nerve will also be inflamed. And the cell bodies for the nerves on the right side of the brain or the head sit right next to the cell bodies for the nerves on the left side or the corresponding left side of the body. So if you have unchecked inflammation in this entire nerve, eventually the whole nerve will be inflamed and can inflame its contralateral or other-sided counterpart, and eventually that nerve will then cause inflammation and symptoms on the other side, almost like a referred pain type of situation. And you can think of it, as I describe it to a lot of my patients, as a forest fire. If you've ever seen a forest, you often see that there's clearings that the forest rangers will make in between the tree lines, so that if you have a forest fire in one area, the embers don't jump that barrier and then set the rest of the forest on fire. And that way, if you have a forest fire in this section of the forest, you have a chance to put it out before eventually the embers flow to the other side and the rest of the forest begins to become on fire as well. However, if the forest is burning over here and is left unchecked, eventually some of those embers will float to the other side and you'll get a forest fire on the other side. And so my point is, if you have symptoms that begin on one side of the body and are left unchecked and untreated optimally for many, many years, it is not at all unreasonable to think that the corresponding areas and sometimes other areas of the head and neck, because their cell nerves, their cell bodies will be sitting next to the nerves that are inflamed, will become secondarily inflamed, and you'll have referred pain in those other areas on the contralateral side. So you can get migraines on both sides. There is a patient that asked, is PRP an option to potentially lessen the pain of occipital neuralgia? So first of all, what is PRP? PRP stands for platelet rich plasma. It's derived from your own blood, which obviously has some plasma that's sort of like the fluid component of it, and it's rich in the platelet component, which is one of the clotting components of the blood. The idea behind how platelet-rich plasma works is that there are there is a high concentration of various growth factors and platelet-derived growth factors specifically that can increase matrix synthesis and collagen formation. And it is thought that, for example, in the use in patients in osteoarthritis, it enhances the expression of a cytokine known as NF-kappa B inhibitor and therefore minimizes downstream inflammation. There is no published data, to my knowledge, on the use of platelet-rich plasma for occipital neuralgia. Theoretically, it could reduce inflammation in the nerve, much like it reduces inflammation in an osteoarthritic joint in those same through those same pathways that I just described. But there's never been any papers that have described definitive efficacy in occipital neuralgia. And in fact, PRP is somewhat controversial even in the use of patients who have osteoarthritis, because some people believe that the data behind the use of platelet-rich plasma is actually a little soft. And so platelet-rich plasma is an interesting idea, but one whose time has not arrived at the present moment. Now, we had another patient that sent a really nice question. It says, following an occipital nerve block, I had a pronounced dent in the back of my head where my neurologist injected. It is tissue thinning secondary to steroids. My head is quite tender. Is that a common reaction? Will it resolve with time? So let's talk about that a little bit. First of all, when people get steroid injections, typically the carrier for the actual steroid, the fluid that brings the steroid in there, is not just the steroid itself, which is also somewhat liquid, but a little bit more viscous. It looks kind of like milk, but actual local anesthetic. So typically when people get a steroid injection, they get either a local injection of local anesthetic first, and then the steroid with a little bit of saline, or they get an injection of the local anesthetic carrying the steroid. Now, the local anesthetic is not to blame in this case. However, the steroid is, because if you inject steroids too superficially in the subcutaneous tissues, you can actually get dermal and subcutaneous tissue atrophy. The dermis is the deeper layer of skin. If you've ever fallen off your bike, as I did many times as a child, that road rash, that deep red area of skin when you skin your knee, that's the dermis. And the epidermis, which is the skin that you and I are looking at as we look at each other for this session, is the epidermis. So the dermis can thin out as a result of a steroid injection, and the subcutaneous tissues can thin out. So it is not at all uncommon, if you inject steroids too superficially, that you can get thinning. Now, will this resolve with time? The simple answer is no, because the tissue that has been atrophied will remain atrophied. New fat cells will not grow, just like new muscle cells do not grow once we reach a certain age, and that is some point during our adolescence. We can have hypertrophy or enlargement of the muscle cells that we have, and hypertrophy or enlargement of the fat cells that we have, but we will not grow any new fat cells. That being said, if you have dermal atrophy, which sometimes happens with steroid injections, there are a number of ways in which you can treat it. One of the simplest ways to do that is to do fat grafting. So you can harvest fat by basically liposuctioning a certain area of the body where you have maybe some excess fat, as we all do, and then processing the fat in a certain way, and there's a number of ways that you can do that, and then injecting it into the area where you have atrophy. And if you have a good set of techniques, then a significant percentage of the fat that you inject will be permanent, and it'll be a permanent result. Another way to do it, if the area is small enough, is you can use one of the dermal filler replacements that people use for aesthetic reasons all the time. So you can use Restylane or Perlane, Voluma, Juvederm. These are just some of the commercially available products. Even Sculptura, which will be a very long-lasting result. And there are a number of ways, therefore, to treat the fat atrophy, but it depends on the size of the fat atrophy, and whether or not it's actually really in a conspicuous location, because if it's in the back of the scalp under your hair, you may decide, well, it's just not that functionally relevant. However, if it has atrophied a significant number of, or a significant amount of the subcutaneous tissue, your nerves in that area may be less protected. And if that is the reason that you have extra tenderness in that area, then that's something that probably should be treated in one way or another. But if you operate on that patient, one of the other things that you can do is something called a local tissue rearrangement, where you harvest some of the subcutaneous tissues in the adjacent area of skin, and you use it to cover to fill in the defect that's created by the steroid injection. Okay, so there are a number of ways to treat that. It is typically thought to be a permanent thing, so it's not likely to go away, but it can be remedied with any number of ways, and usually very successfully. A patient just wrote in and said, are nerve blocks mandatory prior to surgery, and how long do they last? So again, a good question. We've gone over some of these points before, but nerve blocks, in my hands and in my opinion, are mandatory prior to surgery, because what you're really looking for with a nerve block is to see if altering one facet of your anatomy and physiology results in relief. So I saw a patient today from Texas who had nerves in the forehead and in the side and the back, and she came in with 8 out of 10 or 7 out of 10 pain. We injected one set of nerves, it went down to a 4. We injected another set of nerves, it went down to a 2. We injected one more nerve in the back side of the neck, and it went down to a 0, and she left completely pain-free. First time she's had that in many, many years. So the idea, again, behind the nerve blocks, and the only thing that we've done in that patient's case, is temporarily and chemically inactivate one or more nerves. And if you do that and the pain goes away, there is a very high degree of certainty that the nerves that you have temporarily numbed are involved in that pain symptom complex, and therefore permanently doing something to those nerves, whether cutting them and burying them in the muscle, decompressing them, doing a neurolysis, should also help on a permanent basis, because the presumption in most of these cases is that there is some mechanical compression, whether from an enlarged blood vessel, extra tight connective tissue, a spastic muscle, etc. Now, how long do the nerve blocks last? That is a variable question. Again, there's no right answer because, of course, there are a number of different local anesthetics that you could use. My preferred mixture is lidocaine and marcaine. Lidocaine has a very rapid onset of action, so usually by the time you finish your injection, you actually already have some numbness, so it usually works within a few minutes, but it doesn't typically last very long, 30 minutes to 2 hours in most cases. So I combine that with marcaine, which is also known as sensorcaine or bupivacaine. Those are all the same, just depending on which brand you buy. And that has a longer onset of action, so typically 5 to 10 minutes before it becomes effective, but it can last anywhere from 4 to 8 hours. So therefore, by combining those, I get a quick onset of action from the lidocaine and a long duration of action with the bupivacaine. But you don't have to use that mixture. You can use one or the other. Neither is incorrect, but that is my rationale for using those. Now, I wanted to answer a couple other questions, and this is actually in a blog post that I put out this week, which I think is really good because there were a couple patients that had written back about various things that happened during surgery and that I think are important to address because I think they speak to a lot of misconceptions that people often have when it comes to headache surgery. So I wanted to kind of address some of these, and the first one is Dr. Peled, you talk about removing a little piece of muscle in the neck. How is that not going to leave me paralyzed? Okay, so this is a really important question and one that I think has a very, very straightforward answer. And the answer goes something like this. The muscles that we're treating, you can think of, are not unlike your biceps muscle. They are very, very large, and they span a long area. So if you're looking at the semispinalis muscle, it is a muscle that goes basically from kind of the base of your neck all the way up to the cranial base. So it's a really, really long muscle, about yay big, and it's also very, very thick, okay? The amount of muscle that we are removing is about the size of a thumbnail because, of course, the nerves themselves are not the size of your thumb. They're much thinner than that. And that's why they are often not imaged very well, even with MRIs or even in some cases MRNs. Those are MR neurograms, which are MRIs that are specifically designed and in which the buttons are tweaked to highlight the nerves. So because they're so small, you don't need to make a Lincoln tunnel-sized hole in these muscles in order to provide room for that nerve. And in other words, in another point, the greater occipital nerve space that we create is then padded or filled with subcutaneous fat, so that as that muscle continues to contract, and it will continue to contract, that nerve will be pushed against a soft cushion of fat so that it is not pushed up against a very hard and spastic muscle. Now, because of that fact, what you're essentially doing is a muscle biopsy. And people do muscle biopsies all the time for any number of reasons, various forms of myositis, et cetera, et cetera. And those muscle biopsies do not lead to any paralysis, okay? In addition, okay, the nerves that we're operating on for headache surgery are not motor nerves. They do not move anything. These nerves are all 100% sensory nerves, which is to say if you cut all of them to, the 14, 7 on each side that are the primary targets for headache surgery in the scalp and back of the head, you would, pardon the pun, be a numbskull. Everything would be numb, but you would move everything, your eyebrows, your ears if they wiggle, et cetera, et cetera. So the idea that you could have paralysis, while theoretically always possible, because there are, of course, motor nerves that move the muscles in the head and neck and the forehead, et cetera, in the area, if you know how to look for them and you know how to avoid them, then you won't injure them. And one of the things that I use in the operating room is a nerve stimulator, so that if I ever run into a nerve that I think, geez, that nerve is permanently injured and needs to be cut, I always test that nerve first with that stimulator. And if some muscle twitches when I test that nerve, it's not the nerve I'm after. It's a motor nerve, and I leave that nerve alone, obviously, before I cut it. Okay, so I've yet to have a patient who has come back and is somehow paralyzed or weaker than they were before. The one thing I can say is that specifically, for example, with regard to the zygomaticotemporal nerve, that nerve is near a nerve that elevates the eyebrows, which is the frontal branch of the facial nerve, and that's not the nerve you're after. You want to leave that nerve alone. Sometimes just as a result of the operation, just like the nerve itself that you're operating on, the adjacent nerves can also be stunned because, of course, as you push those nerves out of the way to get to the nerve that you're after, they can basically go to sleep sometimes for a few months. And I've had a few patients, in fact, many patients, have an inability to elevate the brow for a few days or a few weeks, and then that comes back as the inflammation of those nerves that we just gently pushed aside settles down. And occasionally that can last several months, but at this point, every single one of my patients has always had a return of function, specifically to the frontalis muscle. That's the muscle that elevates the eyebrows as a result or following that zygomaticotemporal nerve operation. So the take-home message for that, can you have a motor nerve injury and paralysis if you operate on someone? Anything is possible, of course. You could have a heart attack, you could have a stroke during these operations, but it is extremely, extremely unlikely. And, you know, knock on wood, I haven't seen it yet in my practice. Another misconception the patient asked us is, you're a plastic surgeon, how come you are operating on the brain and the spinal cord for these headache operations? And one of the things that is really important to point out is that the type of, or the class of surgery that we're talking about is really peripheral nerve surgery. I don't operate on the central nervous system at all. I'm not a neurosurgeon or orthopedic spine surgeon, so I don't do any spine surgery and I don't do any brain surgery. So in none of these operations do you ever go inside the skull, and in none of these operations, specifically in the head and neck posteriorly, do you ever see the spinal column or the spinal cord. These are all peripheral nerve procedures, and the good news is that typically, with imaging studies like MRIs and CAT scans, you can see pathology in big nerve structures like nerve roots coming out of the spinal cord or within the brain. And when we end up operating on people, the overwhelming majority of these patients have had negative MRIs, for example, of the brain and spinal cord, which indicate that they don't have a brain tumor, an aneurysm, a stroke we haven't realized they had a few months ago when their symptoms started. They don't have multiple sclerosis, they don't have a pinched nerve root or a herniated disc, and therefore it is the peripheral nerve pathology tested and verified by a nerve block that is probably causing their headaches, and that is the target of these operations. So this is not brain or spine surgery, it is peripheral nerve surgery, and it is something that is really, really important to keep in mind. There's a patient that asked, this is a fairly quick question, is the pain in the tongue associated with greater occipital nerve or greater occipital neuralgia? The simple answer is no. You typically do not get tongue discomfort or linguodynia as a result of greater occipital nerve compression. Those are typically different nerves, such as the glossopharyngeal nerve, and you know, there are any number of nerves that innervate the tongue because it's a very sensitive area. But again, the simple answer to that one in one of these times is no. That is not typically done. Lingual neuralgia is not typically associated with greater occipital neuralgia. We've had another patient ask, can these operations be done, this person said arthroscopically, but it's really endoscopically, because arthroscopically means scoping or using a camera to go into a joint in arthro. So I think they mean endoscopically, which is to use these cameras. It's a great question. But you have to think a little bit technically in this particular case. If you were to look, let's say, inside the neck with a camera, what you'll need to do, because you have the skin on top of the subcutaneous tissue, on top of the muscle, on top of the nerves, and et cetera, et cetera, et cetera, you have to create a space within that or a certain tissue plane. So, for example, between the subcutaneous tissue and the muscle, in order to see structures coming through, let's say, the muscle and going into the skin. In order to do that, in a joint, for example, the joint is filled with fluid, and then the fluid is drained before the patient wakes up. If you're going to do a laparoscopic procedure, so for example, let's say you're going to have your gallbladder out, you do that with a camera now. But what happens in that operation, the first thing you do in that operation is you insufflate the abdomen. So you blow it up, and if you're a man, you are going to look like you're 9 months pregnant 5 minutes after that operation starts. And the reason for that is because you now have this big space, and when you put in your laparoscopic instruments to manipulate the abdomen, you don't have the skin sitting right on top of it, so you actually have room to work. When you're talking about small nerves in the head and neck, if you were to create that space, let's say by using carbon dioxide, which is what we use in a laparoscopic case, for example, for a gallbladder operation, you'd have to blow the neck up and insufflate a lot of carbon dioxide into the subcutaneous tissues. That would create huge lumps in the tissue that would take very, very long time to go away, and the tissue would have this subcutaneous crackling type of sensation for a very, very long time. So the answer is we don't have arthroscopic or endoscopic is the better word, approaches to these nerves just yet. You can actually access the supraorbital, supratrochlear, and zygomaticotemporal nerves endoscopically, but there are limitations in terms of what you can do with that. So for example, if somebody has a very convex forehead, those instruments are straight, they're not curved, especially the cameras. So if you're putting your incision here and you're trying to look down there, if you have a big bowed forehead, there's no way to get that camera around where you need it to be. In addition, if you're trying to get to this nerve and you want to decompress it here, that's fine. But if you want to decompress it at the supraorbital rim, you actually can't do that technically looking at it from here, because there's no way to get the camera all the way down. One final, and this is a personal philosophical preference, when you do endoscopic surgery, so for example, a gallbladder operation, you actually have no tactile sensation for the structures you're operating on, because you're using very long instruments and you're watching a TV screen as you do these things so you can manipulate them. So it's not unlike playing a video game. That might work for a gallbladder where you're not really worried about sensation post-operatively. But when it comes to manipulating very, very tiny structures like nerves, I believe that the ability to actually feel those nerves and touch them is actually really important. And I certainly have better control of my instruments if I'm actually manipulating them and using actually typically very small instruments without very long reaches, as opposed to if I were to do the same thing with these endoscopic instruments, which are typically very, very long. So one of the criteria, for example, that I use to decide whether or not I'm going to transect the nerve and bury it in the muscle is, does the nerve have the feeling of a soft, wet noodle? If it does, then that nerve is probably healthy on the inside, and it's an external degree or structure that is compressing it. If the nerve feels taut and firm like a banjo string, then there's probably scarring inside the nerve, and I need to open that nerve up, something called an internal neurolysis, and separate out the individual fascicles to release the scar around those subneural structures in order to hopefully give the patient relief. And so it's actually really, really important that, in my opinion, that you actually have some tactile sensation with these nerves. It's not absolutely critical. There are certainly people who do endoscopic zygomaticotemporal nerve releases. It's one of the well-established approaches. But for me personally, I always like a direct tactile feel for these nerves, and that is why I do not do any endoscopic nerve surgery, even endoscopic carpal tunnel. I like to be able to manipulate those nerves directly and be able to feel them in the operating room so that I can make, for me, the most reasoned decision about whether or not neurectomy, for example, needs to be performed, or an internal neurolysis as opposed to just an external neuroplasty and decompression. So we have many, many more questions that are going to be, going to take a long time to answer. So we will save those for next time, our 8th episode coming up in 2 weeks. We actually will be 1 day delayed next week for our Burning Migraines Questions episode. We have a kind of a unique feature for you. And the reason for that is, so we're going to be broadcasting on Friday instead of on Thursday. And the reason we're doing that is because I've been lucky enough to be featured on The Doctors coming up this Thursday. So hopefully you'll all tune in. If you go to our website, we will have some information for you, or you can request that from our staff. That'll show you when and where and at what time. Though this particular episode will air in your segment, in your neck of the woods, so to speak. And we're going to be talking about headache surgery and featuring the story of one of our patients who unfortunately has had a pretty remarkable journey. So please tune in and see what happens, and then we will be following up with that patient the following day as a sort of follow-up to our burning migraine questions. And if we can figure out the technical details, hopefully allowing you to ask that person questions directly. I'll be interviewing that person, and we'll see how he's doing a year after that show actually taped. So thank you all for joining us today, and we'll see you for our next episode. Take care. Bye-bye.